Okay, next we have an exciting panel to follow up on the last panel, because the things that you learned from the last panel are essential to make the protocol really work. So we're going to talk about CT protocol management updates. Rowena Yip and I are moderators. We're new at our jobs. David has been doing, and Matthias has been doing this all along. So please understand that we're learning our way. I just want to compliment Doreen and her team. That teaching file was really phenomenal. That was a good demo. And we really encourage all of you to contribute, and you're all mentioned as contributors. And I don't know if in the future you can get academic credit for that. May be something that we could work towards. So let's start with introductions. David, you can start with introducing yourself and each one.
Sure. I'm David Yankelevitz. I'm a radiologist at Mount Sinai with a long interest in lung screening and protocol management.
My name is Gratama. I'm a thoracic radiologist and I work in Gelre ziekenhuizen. That's in Apeldoorn in the middle of the Netherlands. And I'm involved in the For in the Long Run project, screening project.
I'm Kazerooni. I'm a cardiothoracic radiologist at the University of Michigan, and I led the development of the LungRad schema, which was last updated at the end of 2022.
My name is Lancaster. I'm MD PhD candidate from the University of Groningen in the Netherlands, and I work very closely with Professor I-ELCAP. One of my supervisors is also Professor John Field, Marjolein Hovermans, and I've done some work on the Nelson data, but now on the UKLS trial data.
Silva, chest radiologist for the University of Parma, involved in For in the Long Run reading sessions and lung cancer screening in Italy.
And good morning, I'm Rowena Yip. I'm co-moderating this section with Dr. Henschke on CT protocol management. So today's discussion is a very important topic, particularly with the increasing use of CT scans and also the penetration of CT screening for lung cancer. And we also want to, and also considering the implementation of screening in limited resources country. So we have several key questions. We have 4 key questions that we want to ask the panels and the audience. The first question is related to volumetric lung cancer screening. Yes. So there are many management protocol out there, and some of them, and most of them rely on getting additional information about whether the nodule is growing or not. And some of the management protocol have are based on using volume, while the others are using size. And we have some of the previous panels have already touched on some of the limitation of using volume, particularly measuring small nodules. So our first question to the panel is whether we should all switch to using volume metrics.
This is a tricky question because, as you heard from just the last panel, to an extent, the ability to do good volumetrics depends on quality of the images. So I mean, the overall answer, I think, is yes, we all should switch to volumetrics, but we all should switch to volumetrics that's of good quality, because you can create lots of problems with it by doing sort of having not good quality imaging, and so you'll get misleading results. So it's a complex answer. We could, as I said, it's the interaction of the quality of your protocol that you use, the types of nodules you do volumetrics on, the quality of the stuff that you're using to do it. But overall, the inherent advantages of volumetrics are, obvious. It's just a question of proper implementation. So that's sort of my first pass at the answer.
Okay, I think it's very important to switch to volumetrics because it's more precise, more accurate to determine the volume. If you want to calculate the volume doubling time, it's very accurate. What are the barriers? I think, first of all, you should have good quality images, like David said. But also very important is the type of software. There are some vendors and they're all a little bit different. And I think it's very important that you have an adequate standardization of the software. And it's well proved to be, you have a very good segmentation. And well, you could question if you should do or do not change the segmentation of the nodule that the AI program provides. Yeah, I think that are the most important barriers. Maybe financial barrier, of course, to buy the software and if it works quickly.
Yeah, I agree with, to some extent, the comments that were made already. More precise measurements, if you have good quality CT data to be able to make those measurements. I think one of the outstanding questions is, does the investment in using volumetric tools change patient-related outcomes? And I think that data is currently lacking. There's not evidence that shows that using a diameter versus a volume approach changes patient-related outcomes. So I think that's one of the core challenges to get radiologists understanding about whether it's important enough to do in their practices. I think in the US, there are some clear financial barriers and that there is no reimbursement for use of volumetric software. There's certainly overhead costs, not just of the tool. The cost of the tool are actually the least expensive component, but it's the overhead of maintaining IT tools in radiology IT systems and then training, education, and use. But fundamentally for me, it starts with the evidence that it changes patient-related outcomes. We have a survey going out to all the registry participants from the ACR to understand what they perceive as the barriers to volumetric uptake, because we see very little uptake in the US.
Yeah, as somebody said yesterday, they were a new kid on the block. Well, I definitely think I am. And I've only really known volumetric measurement in the Netherlands. But I was surprised indeed that it isn't really used in the clinic. Like so, and when I asked the question, why isn't it being used? It was more, yeah, they don't always have a computer available to the software available to do that. But then I questioned, yeah, should we really need to then be working on those solutions, not just accepting we can't do it yet because yeah, we don't have this or this or this available. But if we really agree that it's the best way, which I think we do agree, although evidence is probably needed. Yeah, evidence is needed, which is something we can do in the, for example, we can look at the I-ELCAP trial. We're going to look at whether we can compare volume and diameter measurements and see, do we really have a difference? But I think, yeah, volumetric is probably the way forward. And I think we should be working to a way to get that implemented, which we are, as we mentioned in the previous session, using the phantom to make things as accurate as possible. But yeah, I think we should be working on the solutions. I think a survey to ask what the users is a very good idea because it really needs to translate back to the clinic.
I really think the use of volumetric software goes down to the why are we seeking for volumetrics? What is the reason for? And as Dr. Kazerooni said, on a patient level, are we making a difference? I think the answer is not 100%, but a certain amount of difference can be done. And I think volumetrics plays a role in basically two ways. One way is to give uniformity across readers and with the same reader. So that will become an accuracy metric. And within the accuracy, I would say that volumetrics also helps to minimize what we want to do with screening, which is over-investigation. So at some point when you use volumetric, you can have quite good data in a certain setting on volume doubling time. So nodule growth can be seen sometimes by eyeballing, and then you use volumetric daily experience. You see, probably the total volume of that nodule is not that big. Today, you calculate the volume doubling time is over the threshold that you saw, and then you say, okay, we can wait one more year for this. I think that would be the specific case scenario where software can make the difference. And on the other hand, for especially small nodules, that would be a further guarantee to rule out and go for the next tier screening. And here I come to a sort of kind of conclusion that would include also the matter of reimbursement. I work in Italy, so actually the reasoning is quite different from other areas. But if you take a look on the reporting time using either method, completely manual with caliper measuring, or with software and with the potential of extension of structure reporting, completely automated. So that means that at some point the radiologist might be there reading the images, taking the annotation, confirming or discarding the CAD finding, and that's it. You don't have to write anything more. So does that cost of your time writing the report is enough to give a reason of the reimbursement of the software?
But that doesn't mean it has to be the volume measurement that goes into what you just described. So we've been using nodule detection quantification software for a decade, and it automatically goes into our radiology report, and we can accept or reject it, but we use mean diameter. You can do that with mean diameter, you can use it with volume. So that's not a volumetric specific question. That's a wonderful way to improve the workflow of the radiologist, which I completely agree with.
There's a question, the point Ella is bringing out, does it make a difference, and you want evidence for that, right? So I think that's a question that we all need to sort of think about, because what is it that we're trying to do with volumetrics? We're trying to make a diagnosis. Basically, you're trying to say that by using volumetrics, in all essence, we'll be able to more accurately or more rapidly determine whether there's change in size of the nodule, so that we can therefore diagnose cancer earlier. That's basically why you do the volumetrics. It was to be able to say at a certain time interval, we can think this is cancer, and we made a diagnosis of cancer earlier. Now, and I think that's the extent of what you need to prove. You don't need to prove any longer that finding cancer earlier with volumetric, however you do it, finding cancer earlier is a better thing. I think we all should start with that, because, you know, it's not long ago where the question was, is it better to find cancer when it's 3 millimeters or 3 centimeters? They did the NLST basically for that question, to determine whether it was better to find cancer smaller than bigger. This is another aspect of that as far as I'm concerned. The diameter measurements, you know, at least on a conceptual basis, volumetric should allow you to determine whether you're finding whether you're measuring growth of a smaller cancer than a bigger cancer. You should be able to determine it quicker. So that's fundamentally, now quantifying that's going to be very difficult, and determining, you know, but on a conceptual basis, I think what you really need to do is just demonstrate that you're able to measure growth better with this, and not so much clinical outcome. I think the clinical outcome will be almost impossible to prove without some enormous kind of study. I think we've already have the evidence that finding cancer smaller is better than finding it bigger.
So I'll push back on that a little bit, because medical history is ripe with things that we've said we should do because we think we know why, but in the end don't provide the value that was thought to happen based on what we thought we were going to do. So yes, the general concept that finding a smaller cancer versus a 3 millimeters versus 3 centimeters, that's a big jump as you described. Yes, that seems quite obvious. Does the difference in taking out a small nodule that's slowly growing today versus in 3 months versus in 6 months, when maybe you pick up the change versus based on mean diameter versus volumetric, justify the investment for the clinical gain? And what is that clinical gain when we're talking about lung nodules that are at the 8 to 10 millimeter size, right? I think that's just the fundamental question.
Yeah, but I wouldn't say you're disagreeing with me. I agree with what you said. I agree. I mean, understanding, you know, the impact of it, you know, it's probably going to be, and in fact, it's a quantifiable impact, you know, and that can be gotten. You know, those answers are sort of available. We can kind of start to say how much difference does it make if it's slow growing or fast growing, and size at this size, when it gets to that size, how much time interval will matter in terms of change in prognosis. All of that's kind of available information now, but all of that needs to be put into the equation. I agree with you.
Do we have a show of hands, how many use diameter for the audience and how many use? I'd like to say so.
Yeah, I think the whole diameter discussion and size discussion is a little bit misleading. It all comes from the concept that every nodule is spherical. So what Alice says is only applicable to the spherical nodules. At the moment, a nodule is non-spherical. At that moment, there is an infinite number of diameters, and there's only one volume. And the extrapolation from a diameter to a volume, what you all do also in the guidelines, and it's all over, cannot be done at the moment that a nodule is non-spherical. It's misleading, it's wrong, and should not be in the guidelines.
So I think what you're arguing is that purity is to measure the entire volume of a nodule that is not perfectly spherical. And I understand that as a very precise and pure concept. And I don't think anybody would disagree with that.
Oh.
The question is, does that degree of, is that degree of precision and accuracy necessary to have the outcomes in patients? That's the question.
My problem is that you call it size and volume from a diameter measurement. So call it diameter.
Mean diameter versus volume. Okay, yes, for purpose of clarity, yes.
And don't use misleading terms that you measure volume. You do not measure volume, you measure.
I have
diameter.
never said that mean
Size.
diameter is the same as volume.
Size.
No, size, the definition of a size is to measure something in the dictionary. It does not tell you whether it needs to be mean, max, min, or volume. That is incorrect from a definition standpoint in Webster's dictionary. They both measure size, they just do it differently. So we're going to talk about semantics. Let's look at definitions.
Semantic can be.
And there's the issue of in vivo diameters and volume as opposed to in vitro. So when you resect a nodule and you have an expanded lung and then the lung collapses and what do you measure? And how does the imaging component correlate with the actual size of that tumor, especially if it's a mixed tumor where you have a solid component, non-solid component? What do you measure?
Yes, we've historically had this variation between imaging-based size and pathologic size.
So you're really saying, what is the truth? And there is no truth other than with the phantoms that Rick has.
I want to give you, though, an example before Rick jumps out of his chair. Rick, we showed this case the other day, or that phantom that was on the patient's chest that grew by 40% in seconds. Now, really, a case like that you would have done, and the reason was a distortion that was primarily in the Z plane. So for that nodule, if you measured volume, you would say this thing has changed, it's, and whatever, you can make extrapolations that it's growing, but the volume changed. But if you measured mean diameter in that case, it would not have changed. So in that example, mean diameter would be better. So there's more complexity. There's a lot of complexity to this issue. Overall, if you want to measure change, there should be no question that if you have a good volumetric system, that's a better way to do it than measuring mean diameter. But it's complex. You have to know quality of your aspects of the quality of the measurements. Obviously, volume has inherent advantages because it takes into account all of the nodule. But there are some trade-offs here that are important. And then what Ella brings in is, for small nodules that are growing slowly, the idea that it's not going to be, you're not going to be able to quantify in some clinical aspect the big advantage. And that's true. But I don't know that you need to do that. It's always better. I think there should be a sense that it's always better to get cancer earlier. Whether it's worth to go in the distance to try to do that, that's another question. But if it's easy to do, you kind of should want to get it, the earlier the better.
But from our point of view, when I read CT scans, I use diameter, even though we really developed the volumetrics to begin with. So because it's just more accurate, or we know. We can, okay,
Say that.
so let me back up and say, how small cancers, how many of them are basically spherical versus not being spherical? That's really a question.
Rick, you got to give Rick his money.
Just wanted to say.
Not working.
Now it's okay. So we published a paper with IASLC and I-ELCAP, which was 700 cases from 7 sites around the world, with 25% of them being cancers, and there were 2 time points each. So what we did was we looked at diameter measurements from the radiologists who looked at those cases, and we looked at volumetrics. And we basically said, we separated the sites into high quality and, let's say, standard quality cases. And what we saw was a very clear preliminary data point showing that when we had the higher quality data, our ability to separate the cancers from the controls was better. And I think if we follow that path, we can get you the study that you're looking for. And then the question will be, well, what's the outcome? How's it going to impact outcomes? And I think David has some of that data as well. So if we put our mind to it, I think we can get this answer, as opposed to, you know, a lot of wishful thinking or talking.
Thank you.
So can I ask the panel to brainstorm on an outcome study for evaluating these according to the guidelines that CMS wants to see? What kind of, maybe Ella, what kind of outcome study and how big of a sample size do you think you should have for comparing the two to show improvement?
So what you're asking for is for if you were going to ask Medicare to cover it?
Yes. Let's say you have a volumetric technique that you think is superior, or Professor Utgert is passionate about. So for him to demonstrate this to payers, what kind of outcome study do we need?
I think you have to demonstrate outcomes that improve that provide benefit to the patient. Does more precisely measure the nodule and volume, which volume does, more precisely measures the entire nodule. Does that change the patient's outcomes?
Why do you say change outcomes, though? What specifically are you talking about? Are you talking about extending their life? I
think that's really the question. What can you do to get at that?
Yeah, go ahead.
Does earlier surgery at 8 millimeters versus 9 millimeters translated to volume make a difference for the patient? Does it change the stage of cancer? Does it change cancer-related outcomes for the patient?
I think it's very important to really get down the false positives.
I think the big difference is the decrease of false positives. That's the key difference between the NLST and the Nelson study is diameter versus volume. And all the outcomes are better of the Nelson because of the volumetry. The mortality decrease in males, that's the only thing you can compare.
In a very male-centered study.
Yeah,
by the
no,
way.
and
Yes.
no, and you know the Pinsky outcome, who did the statistics also of the NLST. And in his paper, published in 2013, a reanalysis of the NLST showed very clearly that the male mortality reduction in the NLST is only 8%. And in the Nelson is in a direct comparison with a correction also for the inclusion criteria it's 3 times higher. It's 24%. And that's due to the diameter versus the volume. So the evidence is there. That's one. Secondly, the false positive rate of the NST is far higher, 10 times higher, due to the diameter measurement.
So you're comparing apples and oranges.
No.
No, yes, you are. NLST used the 4 millimeter diameter size threshold as a positive screen. Nobody uses 4 millimeter size threshold as defining a positive screen.
You
in
know
diameter.
when that threshold changed after the outcome of the Nelson study.
No, it didn't, because
no,
we
no.
incorporated it in lung rats
Historically, it's
before the
exactly what
Nelson came
no,
out.
it's
So,
exactly
And we
so wait
used
a
it
minute.
based on
As-
data that came from.
As a
neighboring
moderator, this is a wonderful discussion that we should. Yes, it's a passionate and it's an important discussion, and I thought,
Claudia,
Can I give the answer to my question?
no, that's what I was gonna say. They didn't answer your.
Because I disagree that the evidence is there. I think the evidence needs to be generated in order for payers to adopt it or practice.
So you're thinking of it in terms of payers now. How do you would prove it to
Or
payers?
guidelines.
I still think that, and Matthias brought up the issue of false positives. Ella was bringing up sort of a difference in terms of whether it's better to find cancer earlier. So we're mixing 3 different issues and discussing them all simultaneously.
But I think if you use other predicate approvals for what CMS is covering in the space of quantitative imaging, taking the pathway of, does it impact how many follow-up tests, bronchoscopies, surgeries that are necessary, unnecessary? If you take the pathway of downstream testing, downstream procedures that could be avoided by using volumetric imaging, I think that is the most likely pathway to move in that particular.
Yeah, I agree. And I think Matthias' point on reducing false positive would be one of those outcomes. And FDA and CMS would love to see that. If you reduce from, let's say, 60% to 30%, that's a slam dunk. And now you have evidence, true evidence.
So let's say next year, at the next conference, we have multiple PhDs, theses that have been done on this topic.
Claudia, may I? So I'm not going to against get the debate. But indeed, what is I think you're completely right. In which precision do you need to make a better outcome for the individual? And indeed, there are those 2 mixes. On the one hand, the false positives on the one hand, and really mortality reduction or quality of life or whatever. But I was still interested, and I simply don't know the answer, in that if anywhere, but for instance in the US, radiologists or practitioners or so really would see the evidence or would like to use volumetrics, what would then still be one of the major barriers, you think? So you mentioned a couple of things, but I'm still sort of grappling. What do you think are a couple of major barriers still? I probably around the world, I guess.
So I think setting aside evidence, right? I think there's just basic practical implementation issues. There's cost. There's how do you get your health system to invest in this tool versus the myriad other tools that are coming at them to put into place in radiology practices today. So there's, I think, cost. I think the clinical usability component has gotten much better. The ability to integrate these tools right into the radiologist cockpit and into the interpretation of the report, as you described, have gotten far better. And I think that's something that has been getting addressed as the tools have gotten better and the interfaces have gotten better. I think there's the real practical cost of choosing to do these tools over other tools the systems have to do, getting the time from your IT resources to take care of this problem as opposed to another problem. And if there's not reimbursement for it, I think there's so many tools coming in radiology practices to integrate across every modality and every organ system. There's no reimbursement for the majority of that work currently. And so I think that in the US is a big obstacle. We've designed the survey to go out to the ACR registry participating facilities to try and understand from their perspective across different types of practices, whether they're large, small, independent health system, based on what they see as the obstacle, what they see as the barriers, so that we can better articulate that. We have in lung grads, we've put the volumetric measurements next to the diameters because we believe that there are practices that do want to use it. So it's not that it's an all or none thing. But trying to move the needle and address that and collect some more systematic evidence as to what the obstacles are.
Okay, so this is clearly an important discussion and we'll have much more on it. So moving to the second question, let's see if what the controversy is there. Should we include biopsy, and at what level of certainty do we move forward aggressively? So where should biopsy be included, and how aggressively should we move forward with recommending biopsies?
This is I think a very important question, and I'm not even sure this is the question that the radiologist should answer. I think it's more the question, in my view, it's more the questions that the surgeons should be answering. Because, you know, at what level the surgeons, and ultimately all of us would decide this, but at what level does a surgeon need to know that he's operating on a cancer? And this conversation comes up fairly often. You know, if I tell a surgeon, look, I've looked at this case, I've seen it's been growing at definitely a malignant rate, whether I used volume or diameter, we're still pretty sure that this is, and I've seen it now 3 times, or 4 time points, and it's growing. I'm 95% sure it's cancer. Do I need to biopsy this? And, you know, you can get, most of the time you get an answer, okay, you can go straight to surgery. What if I say it's 90% sure or 85%? What is sort of the cutoff where surgeons are going to say, I want to go straight to surgery with this? Now they answered a different way. They talk about what their acceptable rate of benign surgeries are. And, you know, and you can go around the country from some thoracic surgical practices, they're taking out 40% benign lesions, you know, which to me is very high. So, you know, in the screening world, we've tried to be very careful. We do recommend biopsy fairly often, even though we're pretty certain. So I don't have a definite answer, but this is one of the questions in the therapeutic panel that we're having tomorrow that I wanted to bring out and get the surgeons. The radiation oncologists are faced with this more frequently because a lot of times their patients are the ones that, you know, people don't really want to biopsy because they're kind of sick and you just want to treat them. And they have to make this decision more often about just going straight to definitive therapy. So this is a complex one, but I think that's what I wanted to say.
Thank you. I think if we have a lung rats, is it working? Yep. I think if we have a lung rats 4 lesion, we could suggest a biopsy, but I think there's a role for the radiologist eye. For instance, if you have a very small lesion that's just above the size criteria, I think you could decide to do a follow-up, for instance, for 3 months, to postpone a biopsy. And I think in that situation, then it would be advisable to use the volumetric because it's more precise. On the other hand, you can do some morphology. For instance, if you see some signs of infectious disease, you could suggest also a follow-up, for instance, 3 months, see if it disappears or not, and then you're sure. And maybe if you can look at morphology, if it's a ground glass lesion or a subsolid lesion, you could decide to postpone biopsy.
So would you have a level of certainty, would you say?
I think some of certainty comes from the follow-up, I think.
Okay. So
Yeah, I agree with David. It's a little bit nuanced. If you have a high pretest probability based on in an individual patient, at what percent, is it 90, 95%, you go directly to surgery? We see that happening more and more. But we also see on the flip side of that, because of navigational bronchoscopic techniques, we're seeing nodules that used to not get biopsied now before they go to surgery. So we're seeing kind of two diverging things happening with the ability to get to more peripheral things with navigational bronchoscopy, leading to more bronchoscopies for smaller nodules. But then we're also seeing the trend of people with a high pretest probability of cancer not having biopsies. And they're both kind of happening at the same time.
I would say, I don't think we can have one rule that fits all cases. I think a nice example is from Croatia, where you have a lung nodule clinic and you discuss it in a multidisciplinary team, where the radiologist can say, yes, I can access this using CT guidance, or the pulmonologist says, no, I would do a bronchoscopy and I can access this quite nicely. Or they say neither are an option, actually. This is too dangerous, or we're not totally convinced. So then let's do another 3-month follow-up. And it's a decision which you see is very nice when you sit in, for example, I've sat in the expert panel meeting of the 4 in the lung run. It's very nice to hear this discussion of how you can best approach it. And I think that will lead to the best outcome for the patient, probably.
Yeah, histology confirmation is kind of a safe bet for everybody before acting. But indeed, we've seen evolution, and the example of radiation therapy is excellent. We're gaining more and more weight as radiologists in characterizing these lesions and saying given the likelihood of that finding being a cancer without the possibility to get into an histology. And this would be one scenario. But on the other hand, yeah, I think biopsy before invasive procedures, more invasive procedure at least, should be warranted. Yeah, because it's we've seen also we see also granulomatous disease showing slow growth over the time. And of course, biopsy is not the only way to. You can also use bronchoscopy for several characterizations of the disease going on. As Jan Willem was mentioning, some information can be going on. And at some point, even biopsy could not be enough to rule out, because we know in front of a negative biopsy, we're not 100% sure of that. But I think the standardized pathway towards the management of such nodules of high suspicious would be still biopsy in my mind.
I think the other thing we haven't mentioned is patients and what they want and what they prefer. There are going to be some patients whose preference is to go directly to surgery because it doesn't matter what the biopsy shows to them, whether it's negative or positive. They're going to want it out. And there are other people on the other side of it who, I was just reading a medical record for a patient I read a CT on last week, where the patient wants to have continued follow-up of a nodule that's growing that we all think is probably cancer, but they're deathly afraid of having lung removed, any of their lung removed. So you have different spectrums of patient preference and what they're willing to live with or not in making this decision about biopsy and surgery.
I want to add an additional point. It's not just patient preference, there's surgeon preference too. You know, well, because, you know, and this came to me, I've been doing biopsies for a long time. And one day I had a discussion with one of the more junior surgeons at Mount Sinai. And he said to me, you know, I operate differently when I know it's cancer. If I know preoperatively that you biopsied it and it's cancer, my whole approach to how I'm inside the chest and what I do is different. And I thought that was a really interesting comment. And I don't know if the other surgeons, but this is the kind of thing I'm very curious. You know, we have many surgeons in the room who are about to jump up and say things. But I did find that a really interesting comment. That the approach to operating, their confidence level, how they approach the lymph nodes, and all of that becomes very different once they know it's cancer already.
Well, should there be a kind of set parameter that in a screening program you should have surgical intervention in only, let's say, 20% benign,
That's current
10%?
standards.
What is there a standard that should be implemented.
People talk about having, as a quality metric for lung cancer screening is the benign biopsy, the benign surgical resection rate. And I don't know that we have consensus as to what that number is, and it may vary by geography based on things like background granulomatous infection, endemic fungus.
Just a brief comment. The discussion of the cases yesterday got pretty anarchic. And I think that application of lung cancer screening requires discipline. It requires, for example, adherence to an algorithm. And we haven't heard anything about the I-ELCAP algorithm or the Nelson algorithm, but I think the data shows clearly that when you apply a diagnostic algorithm in making those decisions, that you get much better results than, for example, in the NLST trial, where an anarchic approach was used with people just choosing whatever they wanted to do.
Well, let me also clarify that because, NLST did not have a defined protocol that said you did A, B, C, and D because it was not paid for by the trial. They did give us a recommended protocol in which to follow, and we generally followed it. So it's not completely that it was anarchic, anarchy, and the way we manage nodules or chaos.
Total chaos.
Just to clarify that.
Excuse me, let me clarify. The rate of benign resection was substantially higher in NLST than it is in I-ELCAP.
Yes, and we used a smaller size threshold back then that we know we don't use anymore for defining positive screens. I mean, if you think of when NLST started and where we are now, and the trials that are being designed now are being done differently based on knowledge that's been gained along the way. And that's important that we do that.
So can we all agree that a protocol is important? Communication among the surgeons and the radiologists, multidisciplinary is important. And maybe we should kind of see what it is across the board in screening programs and report it.
Well, we're going to explore tomorrow, I hope, some of this idea about the surge, what level of, outside of the screening context, what is your rate of benign surgeries is acceptable to surgeons? And it's, I think you'll see differences in hospitals that do a lot of biopsies versus those that don't. So this idea of level of certainty, I think, is very important. And, at what level of certainty do we go forward and say, okay, I think you can skip the biopsy. I mean, and these are sometimes, as Ella points out, these are not hard rules because some patients will have very different feelings. And, some patients are very comfortable with the idea of observing longer and being more certain. Others just get it out of me. So I'm telling to surgeons, you guys know this better than anybody. So.
Okay, so we have 15 more. Is there another?
Two, me and then Ray. Doesn't what I feel more recent data showing long-term survival for early stage change your willingness? And maybe just panelists quickly answer that means you're more willing to have a higher negative biopsy rate because there's a likely clinical effect if you catch the cancer early. Whereas maybe earlier you thought the cancer is going to come back anyway, so you don't really bother.
Well, you get additional levels of certainty the more you wait. And that's another thing you sort of have to balance. If it's cancer, even if it's slow growing, you wait long enough, it's going to declare itself. The question is, how much do you lose prognostically by waiting? That's always the balance. And that's why I was so interested in the companies that we had up yesterday, because ultimately those products of all the technologies that are saying, hey, we think this is, malignant, you're giving a malignancy score. Basically, you're trying to avoid waiting X months to see if it's growing or not. I mean, that's the value of the product. Can you avoid the wait? And what I was trying to get at was, how much do you lose prognostically by waiting? If it's very little, then you should always wait. And if it's more than a little, then you better hope that your tools are predicting very well. But that's the idea. These are the balances that we're all sort of trying to figure out right now.
Thanks. So back to the acceptable benign resection rate. So David, you're very trusting of your surgeons. That's good. But I think that
Some of the surgeons.
So everybody has skin in the game, including the people who have to pay for care, and of course the populations we serve, right? So the question of what is an acceptable benign resection rate clearly depends on perspective. So, for example, two surgeons, one practicing in a university environment where the volume of work he does is not directly linked to his income, and one in a community healthcare environment where he's entirely RVU based, kill what you eat. The one in the community healthcare system is not going to care about it.
Eat what you kill.
Sorry, eat what you kill. Yes, there you go. Eat what you kill. Hopefully it's dead before you eat it. So that person is not really going to care about a high benign resection rate because he gets paid the more he does, right? So I think we can't escape the need to focus on this. In a granuloma endemic region, for example, where the issue of false positives is really, really problematic. And unfortunately, in the United States, those regions also are overlapping with the cancer mortality belt. How do we go about agreeing on a number? In the NLSC, it was about 25% benign surgical resection rate. In the UK, David Baldwin tells us it's as low as 6%. Where should we put this? I don't think we can just leave it floating. Where should we need a number for people to work towards, and what should that be?
In I-ELCAP, we had worked out that really, if you follow the protocol, you would be at 5% benign resection rate. But basically, we probably were closer to 10.
So 10%, is that a number we should post? We need a number for people to aim.
That 10% was what I was thinking in my head before Claudia said it, that seems to be where we are now, at least in the US, where we could achievably get to. It may not be where we need to ultimately get to if we have better tools.
Okay, proceeding to the.
Okay, sorry. Yeah, so our next question is if there's a role for standard dose CT scans or PET scans. Start off with Dr.
Okay. Well, it depends a little bit on the context, but I think, especially for things like nodule assessment, well, I have mixed opinions on this. In general, I think the scans are, we're doing very well with low dose scans, and I think we can keep it there. The question comes up, I think, with standard dose is once you're kind of going down the path of evaluating lymph nodes and the hilum and that sort of thing, people start worrying about using standard dose. I personally think that there's very little role for standard dose scans in the evaluation of lung nodules. As far as PET scans go, I also think there's very little role for PET scans in the evaluation of nodules. I think, yeah, especially small nodules. Although I will say that sometimes, on rare occasion when I'm stuck, I will say, well, get a PET scan, but that's more for kicking the can down the road, I think. Yeah, I think there's very little role. As a fast answer, I think there's very little role for standard dose and very little role for PET scans in routine lung screening.
I agree with David. I think standard dose scans, you get a high quality. Perhaps you could define better whether there's fat in the lesion or not. Then you could think of adding contrast medium, but I think that doesn't add a lot for characterization of the nodule. Perhaps if there's an arteriovenous malformation, that's not frequent. A PET scan in the screening setting, I think, is not very useful. You either want to prove that it doesn't take up FG, but I think there are two problems. If you have a tiny lesion, a small lesion, then the chance that you will prove that it takes up FDG is small. On the other hand, there are tumors that slow growing adenocarcinomas that take up little or few FDG. So then you won't prove that it's, well, you could miss it because you can't prove that it takes up. And on the other hand, you want to prove if it's malignant that it takes up FDG. But infectious causes also take it up. So then you don't know for sure. You have no high level of certainty. In our hospital, we once operated one patient that we thought would be malignant. And afterwards, it proved to be tuberculosis. So you don't get very high levels. And so I agree with David, no added value.
Yeah, I would agree. I don't think there's a role for standard dose CT in further investigating nodules detected at screening. And I think there's very little role for PET CT, with the caveat that we do have some interval cancers that develop that are larger, that are not your small nodules anymore. That, you know, all of a sudden you go from a 5 millimeter nodule or a 2 millimeter nodule to a 3 centimeter nodule within less than a year. So I think there's going to be some patients where it's part of a staging workup, but I think it's very small.
Yeah, I would also be in agreement. I think as Ella mentioned yesterday and Jan Willem just mentioned that PET, for example, yeah, you would also see that with infection. So what is the added value then? Does it make it even more confusing maybe? So I would agree it doesn't have added value in screening.
So I think I agree with everybody, and I'm not surprised, probably. I think the amount, the role for standard dose scan and PET is actually found in the numbers of lung cancer screening, because we aim to early stage, and we get early stage 3 out of 4 cases, right? 70% are very good. But in that one case of positive finding, actually a standard dose CT with contrast could help in the stratification of mediastinal risk, because in some case we don't succeed with early diagnosis. So that would be the amount of relevance for that standard dose CT within a lung cancer screening scale, which means I would say in about 25% of positive findings.
So that's amazing. Oh, I thought we had great consensus here.
Want to make aware there was a recent publication here in April in the Journal of Nuclear Medicine.
There was a recent publication in Journal of Nuclear Medicine, April, where they came from Heidelberg with and they compared in a small number of cases where lung nodules were negative in an FDG PET. They were positive in a complete new tracer that is called gallium FAPI. And I think they claim this is a brand new application, which is very promising. That's what they claim. And what they show here in this very limited, I think it's a number of 20 patients or something, but all negative with FDG. So it could be a game changer. And I think then we would have, from the nuclear side, we would have a game changer for those nodules where we have no answer.
Okay, and then those would have to be available widely also. But that was wonderful consensus. So, and I agree with that consensus also. So the next question. Is there a role for risk assessment in determining intervals for screening or for follow-up management? I'm sure this will be controversial. So
I suspect it will. I think that this extends even beyond lung cancer. We're seeing this in the breast cancer world as well, and we have I know Robert Smith in the back somewhere. He's probably would want to weigh in on this as well. But in general, I think risk should not be determining screening intervals. My view on the idea of risk assessment is screening is sort of either you're eligible for screening or you don't get screened. Once you reach a threshold of being screened and you're in a program, you want to get the same benefit as anybody else who's in the program, meaning you want your cancer found early. So if you've reached a certain threshold of getting screened, and I say to you, well, you're at the lower end of the risk of getting cancer, but you're still high enough to be in a screening program. And then I say to you, but we're gonna delay your next round of screening by an additional time interval. So instead of getting annual screen, we'll say you're getting 2-year screen. If they happen to be the unlucky one that has a cancer, they've now waited 2 years, as opposed to the person who might very well have been a higher risk, but would have found their cancer at 1 year. So the idea that you would be delaying their cancer diagnosis longer just because they're lower risk, the critical question would be, do the patients that are lower risk have cancers that behave differently? If we can say lower risk people have slower growing cancers, that's one thing. But once you're saying the cancers behave the same and they're at high enough risk to enter a screening program, the intervals, in my view, should be the same. I'm not in agreement that we should be changing intervals based on risk.
Yes, risk assessment is indeed used for the enrollment for the screening program, but I do not think that we can, after that risk, change the interval. Perhaps if you have a subsolid lesion, you could say, well, maybe you can wait 2 years, but on the other hand, the client was accepted for the program, enrolled for a program for the pre-test risk. So I think we should keep to fixed intervals.
Yeah, so I'm uncertain about whether we should use risk assessment for determining screening intervals. So I don't feel strongly either way based on that.
Change that.
I feel strongly about some other things, but not that one. As to follow-up management, I think we do use risk assessment in follow-up management, at least because we might not use non-radiology features, but we're using radiology features to decide follow-up management time intervals. So we're already using assessment based on radiology findings for follow-up management.
Yeah, I would say we need the evidence for it. I think we're very lucky that the evidence will come shortly from the 4 in the lung trial when that's finished, which are looking at annual versus a biannual. And if then you miss anything in between the different screening rounds and how that performs. So I think that's going to be a big game changer in whether we can look at changing the intervals. And I'm also not sure whether we can, we're talking now about risk assessment. I think that would vary per population we're looking at as well. I don't think as a European country, we can then make a decision for another country because of course, if cancers are behaving differently, growing differently, we would then need to look at that in each population, I think, to determine the risk assessment.
I think have a slightly different opinion. And probably it comes from personal experience over the BioMind study where triennial round was offered to negative baseline. Negative baseline was meant for nodules smaller than 113 cubic millimeters, what you would call long grad 2. But in addition to that, as Hella said, there might be further risk stratifiers, which are biological and not radiological. And in that case, that was a circulating marker called microRNA. Well, that case in that population, which was made up of more than 4,000 people, also the triennial round worked quite well. Probably a bit too much without the marker, because indeed the biological marker took up some cases. The other interesting thing is that those that you might call long grads 3 that usually go to 6 months, they went to 1 year round. So what you would do for long grads 2 usually. That was not a determinant for delayed diagnosis. So I think risk stratification after CT might help to adopt the screening intervals. Pushing to biennial, I think, can be done, but probably also the longer interval for intermediate nodule might be acceptable. And I know I'm saying something probably not agreed here.
Well, so we're just at the time limit,
Yeah.
but if there's a question, a short question from the audience, because then we go to coffee break, which is very important.
Start on time.
So any comments from the?
Good.
No questions? Okay, then we're ready for coffee. Thank you very much for the panel.